Kelsey, do you want to just share your screen whenever you're ready? But I'll just give a quick introduction. I do expect quite a few more people to join us here based on our registrations, but we'll get started on time and so that we can finish on time. I appreciate everybody who is joining us here today. I wanted to thank you for coming and really appreciate you coming in the evening as well. I know most of you are doing this after a long day, so thank you very much. And our speaker tonight is Dr. Kelsey Roden. She is a family physician here in Victoria. And Kelsey completed the Addiction Medicine Fellowship a couple of years ago. And so she's doing most of her work now focused on addictions. And so she is going to lead us through a talk tonight focused on alcohol use disorder. And really, I think the main message that I hope that everybody gets out of the presentation tonight is that there are a lot of options for patients that are struggling with alcohol, and that everybody here can play a role in supporting patients to reduce their alcohol intake or to completely eliminate it if that's what their choice is. And so feel free to write any questions you have in the chat. I will monitor that. And, you know, at certain times, maybe I'll interrupt Kelsey if she is moving along really quickly. So feel free to ask questions as we go. And then we'll also have some time at the end for questions. So please do keep your questions and think of them as we go. And especially if anybody has any interesting cases that maybe they've had themselves in the last little while that you weren't exactly sure what to do with, those would be great to review as well with Kelsey. So I'm going to pass it over, and I hope everybody enjoys tonight. Thank you.
Awesome. Thanks, Amanda. I am definitely not a Zoom guru, so if you are having troubles hearing me or have a burning question, then you need to interrupt me, please go ahead and do so. So Amanda already said most of what I was going to say at the beginning, just where I come from. For a little bit more context, for those of you who are also clinicians, I'm currently working at Kool-Aid, which is an inner city addiction medicine and family practice clinic, mostly for marginalized and homeless people. As well, I work at the consult service for both Vic General and Royal Jubilee Hospital here in Victoria, managing alcohol use disorder, alcohol withdrawal, and mostly opioids, as well as at the RAT clinic, the Rapid Access Addiction Clinic. So that's the clinical context that I'm coming from. Hopefully that'll be helpful for some of you with your questions later on. So before we get started, I do just want to acknowledge the impacts that colonialism continues to have on our Indigenous populations in BC today. I think we're all coming from different areas of BC this evening. So if you can take a moment to think about the land and who that belongs to, where you are right now. For me here in Victoria, I'm on the territories of the Lekwungen speaking people. This is this song, He's Wasainak and Esquimalt Nations. And I'm really grateful to be here. I have no disclosures to declare. For today, hoping that we will be discussing the newish standard of care put forward by the BCCSU. This is published in 2019. We'll be talking a little bit about issues that are keeping people currently from accessing care. And I'm really hoping that we can foster a sense of greater compassion for people struggling with alcohol use, and that each of you will go forward with more knowledge and more comfort in diagnosing and treating this so that we can treat more people in BC. As far as content this evening, we're going to start off by talking a bit about prevalence of alcohol harms in Canada and BC. We'll talk about epidemiology and go over Canada's low risk drinking guidelines. Some of you may already know the guidelines. For some of you, it might be a new concept. We'll then move into approach around screening and brief intervention and what that means, as well as withdrawal management. We'll talk a little bit about outpatient as well as inpatient, and mostly focusing on how to decide between outpatient versus inpatient and when that's appropriate. And then we'll finish off by talking about relapse prevention, and that is medications as well as non-pharmacological approaches. And as Amanda said, I am happy to take questions throughout or save them for the end and we can spend some time on them. So in thinking about why we care about alcohol use disorder, it is quite harmful as far as health impacts and costs associated with that in Canada and BC. This data comes mostly from the Canadian Centre on Substance Use, found that 18% of Canadians aged 15 or older would have qualified for a diagnosis of alcohol use disorder at some point in their lifetime. And so Canadians, 1 in 5 Canadians aged 12 or older are drinking in what's considered excess, so above the daily or weekly recommended limits. We know that alcohol contributes to 8% of deaths in Canadians aged 0 to 64, so lots of really young deaths. And in BC, 26 deaths per 100,000 are related to alcohol. So major impacts. From just a health specific perspective, we're not going to go through every single thing that alcohol related harm or alcohol causes. But when we're thinking about the brief intervention and screening and why we're trying to catch this earlier rather than later, we're really trying to prevent a lot of these long-term harms that are associated with alcohol use. So cancers, hormone dysregulation, immune system, mental health. That's a big one I'm seeing in my practice. I'm sure many of you are seeing with COVID is the significant mental health harms associated with alcohol use as well. From an economic perspective, alcohol is costing the system more than tobacco and more than other substances combined. And when the data was pulled for this, it was looking at healthcare utilization as well as lost productivity and criminal justice costs. So BCCSU put out a guideline in 2019 around management of alcohol use disorder. The intent is to bridge the gap between what we're seeing in research and clinical practice. About 20% of Canadians annually are engaging in what's considered high-risk drinking, so drinking above the low-risk drinking guidelines. And that generates, as we just talked about, health and social problems, long-term health impacts, large society costs. But despite all of this, high-risk drinking and alcohol use disorder are often unrecognized and untreated. So this was a study just talking about where alcohol use disorder is coming from. I think most of us can probably already knew this, that basically it's a mix of nature and nurture. But these twin studies were finding that both environment, abuse, PTSD, trauma, physical injury are a major factor in developing not just alcohol, but also all substance use disorders. And then from a genetic impact, there's an emerging field of pharmacogenetics that's looking at not just how alcohol and alcohol harms are related to specific genetic propensities, but also different medications may be more appropriate for different genetic backgrounds. It's not a studied enough field to be able to change the way we prescribe at this point in time, but it's something to keep your ears out for. And then in talking about, and we'll get into this study a little bit more later on, but this was a large meta-analysis looking at 122 different RCTs around pharmacotherapy for AUD. I looked at 3 approved medications, that's naltrexone, acamprosate, and disulfiram, as well as 23 different off-label ones to try to see evidence around treatment. And the overall conclusion is that there's lots of evidence to support the use of pharmacotherapies in AUD. And as I said, we'll talk a little bit more about this at the end of the talk. However, despite this, there's unfortunately a low impact of pharmacotherapy use, at least in BC. So before we know how to treat it, we have to know how to find it. So when we're talking about screening for alcohol use disorder, we're usually talking about measuring standard drinks. So standard drinks, when it's beer or cider, this is 5% alcohol, 341 mils, which is a little bit less than a standard can. When it's wine, this is usually 12% content and about 5 ounces, so less than what they're often offering in restaurants. And then distilled alcohol is usually 40%, 1.5 ounces. Some alcohol comes in higher percentages, but most of the time it's 40%. And I just wanted to show you, if I can here, this is a tool that I like to use. This is a standard drink calculator. If you just Google UVic standard drink calculator, then you'll find this. It's particularly helpful when patients are reporting perhaps their beer or cider consumption to you. And the reason is that they might say, oh, I drink 10 beers a day, but 10 beers of 8% tall cans is a way different story than 10 5% beers that are 355 ml cans. So you can, enter your whatever it is in here, 355 mils and then 8% beers. And now you've got your standard drink per beer. And then obviously you can calculate more accurately how much they're actually drinking. So I use this one all the time. I think it was developed by the Canadian Centre for Substance Use. And there we go. Okay, so as far as the low risk drinking guidelines, hopefully some of you have seen these before. If not, that's okay. They were published by the Canadian Centre on Substance Use, intending to help people educate themselves about how to reduce long-term impacts related to alcohol. And so they're gender specific. For women, it's 10 standard drinks per week, no more than 2 drinks per day. And this is part of why it's so helpful to understand what standard drinks are. For men, it's 15 standard drinks per week, no more than 3 in a day. And it's really important with your patients to stress having non-drinking days. The reason for this is, of course, to prevent development of tolerance and habit formation. The guidelines around youth is always, if we can, to delay drinking until adulthood. But from a harm reduction lens, understanding that might not always be the case, you can advise your youth population that if they're choosing to drink, ways that they can stay a little bit more safe is never drinking more than 1 or 2 drinks at a time, and never more than 1 or 2 times in a week. And then it's always important to say they never meant to exceed the daily or weekly limits. I mean, youth can be so vulnerable to harms related to alcohol. It's usually binge drinking that we'll see in the youth population. And so that's where exploring different hazardous situations, that kind of thing, is really important. We'll get into that in a little bit as well. For seniors over 65, for women, the recommendation is 5 drinks or less per week and no more than 1 per day. For men, it's 7 in a week and no more than 1 or 2 in a day. And especially with seniors, you know, we see a lot of medication interactions. Many seniors are on sedating medications. This is really important when thinking about alcohol use. Seniors also have decreased metabolism, decreased total body water, and that means they have a higher blood alcohol content, which means potentially higher health-related complications from alcohol. And then, of course, with aging comes cognitive risks and fall risks. And of course, alcohol is only going to exacerbate that. As far as who we should be screening, the answer is everyone. And the answer is, if you can, annually. Don't be shy to ask questions. And I think the more that you can make it just a part of your routine practice, for those of you who are family doctors, the better it's going to be as far as finding this overall. I think a lot... I did a study when I was in residency looking at the number of family doctors who were asking patients about alcohol use, and it was less than half of the time. That was back in 2018, so it might have changed since then, but it's why we do these kinds of talks, is to try to increase the likelihood that we're screening for this at an early age for patients before they're developing red flags. So I think most of us are pretty good at seeing liver enzymes that are elevated and asking people why. But if we're screening it for it routinely, then we can catch it before they even have any sort of hepatitis going on. Obviously, when you're screening, it's important to be adopting caring and non-judgmental manner. When I was in med school, which wasn't all that long ago, we were always taught to ask about alcohol and then assume it's double the amount. And I don't know that that's always true. Depends on sort of the manner that you adopt. But, you know, the more welcoming and the more judgmental you can be with your patients, the more likely you're going to get an accurate report, as well as the more likely you're going to get some real concrete goal setting with your patients when you're going through some of the brief interventions, which we'll get into in a moment. How to screen. There are lots of different questionnaires out there. For those of you who use Pathways, these questionnaires are found on Pathways, which I actually just learned yesterday. The tool that you use can depend on who's doing the questionnaire. It might be you, might be a self-questionnaire that they can fill out in the waiting room. Some tools are connected to EMRs, or you can actually ask for them to be connected. There isn't really a right answer. I think probably simple is best. As far as multi-question screening interventions, CAGE is probably the simplest. It's just 4 questions, and you can Google the questions, but it's about cutting down and annoyance around people asking about drinking, guilt, and having eye openers. So that's kind of what it stands for. Because it's an acronym, it can be easy to remember. I think in general, just having a systematic approach, so choosing a screening tool that you like is going to be is going to increase the chance that you are screening everybody. A really simple opportunity is just to ask a simple screening question. So these aren't necessarily as good, as in they're not as sensitive or as specific as the regulated questionnaires, but they are about, I think it was 60, let's see my notes, 60 to 90% sensitive. So that's pretty good as far as picking up at least risky drinking. So for both of them, they do require follow-up questions if the answer is yes. But you can just ask, do you sometimes drink beer, wine, or other alcoholic beverages? The other one listed here is how many times in the past year have you had 5 or more drinks, or for women, 4 or more drinks? And then if the answer is yes, then you can start to characterize with them, okay, how many days in a week, how many drinks in a sitting? And of course, other relevant questions might be complications or consequences they've had, such as driving safety or ending up in the hospital or whatever that might be. But it's a good place to start. So if you screen someone for alcohol use disorder and you talk about their weekly amounts or their daily amounts, and they are within the low risk guidelines, then it's important to just review what those limits are, why those limits exist, and just positive reinforcement as far as staying within those limits. And it's important to remember that depending on your relationship with your patients, they may or may not have been fully forthcoming with you. So that's why I think it's particularly important to still review the limits, even if they're within those limits, just because maybe they didn't tell you the whole truth, and it's helpful for them to have that education point so that they can internalize that and change their behaviors if needed. If they're above the limits, then you start screening for alcohol use disorder, and this is more into the DSM-5 criteria. And we're not going to go through all the DSM-5 criteria. I don't have every single question memorized, and I am an addiction medicine specialist, but generally it's screening for, the physical dependence around a substance, the consequences, both health and social consequences, and then hazardous or risky use. It's easy to just Google what the, if you really want to be specific, you can always Google what the criteria are and go through all the questions with your patient. But the other side of this is if someone says, I never drink at all, it's an important question to explore. Maybe they have a family history that's relevant for you to know as a primary care provider. Maybe they themselves are in recovery. That's also really relevant information. So an answer of no on the screening doesn't mean that the questions necessarily stop there. So if a person is drinking above the low risk drinking guidelines, but they're not qualifying for alcohol use disorder, that population should be receiving what's called brief intervention. And the next slide will talk specifically about what that is. If a person meets the criteria for alcohol use disorder, they should be getting brief intervention, pharmacotherapy, and referrals as appropriate. So what is brief intervention? These are the term coined to describe time-limited sessions. So it's really 5 or 10 minutes. Should be grounded in motivational interviewing and using a harm reduction approach to help people recognize what their drinking behaviors might be, why they might be concerning or impacting their health, especially in the long run, and then strategizing around how we might make some changes. And motivational interviewing in general is a really important tool for, I think, all clinicians to have. I might be a bit biased in that way, but it's patient-centered, it's goal-oriented. It's basically a spirit of interviewing where you're helping patients or you're evoking from them what their own goals are and what health changes they might want to make, and then strategizing with them on how they might make those changes. And I think it's actually, patients don't respond all that well to lecturing, as most of you probably know. So using these very short interventions over time is a really important approach rather than having a long chunk out of your day spent talking to a patient and providing in-depth counseling. The other thing to think about is for those of you who maybe work more in acute settings, acute care, where you're not going to have that follow-up, you can still provide a brief intervention. And if everybody is providing these brief interventions, that's still collectively a similar effect as having these frequent and short interactions where we can explore this with patients. So just because you're only seeing patients once doesn't mean that they shouldn't necessarily get this intervention. This was a Cochrane review done in 2019 just to show the evidence behind brief interventions. It's pretty in-depth, looking at 34 RCTs, overall found that people who received brief intervention, especially in the primary care setting, had lower alcohol consumption compared to controls. And this was even at a year of follow-up, so pretty good retention. And then the meta-regression analysis showed that short sessions were actually as big or as important as long interventions. So maybe short is better because it's better for you in your busy day and it's as effective. Okay, withdrawal management. Maybe before we do that, does anyone have any specific questions about the brief interventions and such we've talked about? Okay, I don't see anything in the chat, so I will move on. Oh, if I can move on. There we go. Okay. So as far as withdrawal goes, we'll just spend a little bit of time talking about the neurobiology of withdrawal, and then we'll get into more specifically how to manage it. So our bodies are always trying to be in homeostasis. With respect to alcohol, we're talking about GABA and glutamate. So GABA being inhibitory, glutamate being excitatory. When alcohol intoxication is happening, there's excess GABA. So now that's the reason for the calmness, the sedation, all those things that we see related to alcohol intoxication. That's overpowering the glutamate aspect of things. For chronic alcohol use, because our brains are going to be in that homeostatic balance, it will upregulate the glutamate receptors in order to balance the exogenous GABA. And so you end up in balance. This is what tolerance is. This is why you can see someone who chronically uses alcohol in a heavy way, who has a blood alcohol of maybe 80 and they look completely sober. This is why. So withdrawal is where you're removing the exogenous GABA rather acutely. Suddenly you have this unopposed glutamate, and then you get too much excitation, not enough inhibition. This is why seizures and DTs happen. So 50% of people with long-term heavy alcohol use will have some withdrawal when they stop drinking. Most people will have symptoms that are mild to moderate. I'll show you a slide on the next slide is going to be more of a picture depiction of the time course, but can start 6 hours after. It can even start less than that as far as hours after your last drink. The peak intensity is usually 1 to 2-ish days and then resolves within 5 to 7 days. That said, some people will have a little bit of subacute withdrawal, which is usually more characterized by like anxiety and some insomnia for days to weeks after they've quit drinking. This is the picture that I like to have sort of imprinted in my brain when I'm assessing someone in alcohol withdrawal. And so you can see, as we talked about, around the 6-ish hour mark is where you start getting the significant increase in symptoms. Sometimes people, as you've probably seen, sometimes people will present with seizures, and then the rest of the symptoms will kind of come a little bit later. So this is sort of this is where most people fall, this moderate and the minor and the moderate withdrawals. Hallucinosis, which we'll talk about in a second, is usually more day 1-ish into day 2 or 3. And then DTs is the red line here. This is potentially usually day 2 to 3 is where it will show up, and then can be there as long as 5 to 7 days later. I've actually seen a couple of cases coming in where they had quit drinking, everything was, well, it wasn't going great, but they weren't seizing. And then they came into hospital with confusion and hallucinations, and it really did look like DTs around the 5-ish day mark. So it does happen, but it's uncommon for people to be entering DTs that late. It's usually earlier on. As far as symptoms, I think most of us have probably seen this many times, but talking about tachycardia, increased blood pressure, tremor, nausea, vomiting, these are all basically the CWA protocol questions. 8% of people who do have symptomatic withdrawal might have transient hallucinations, and these can be visual, auditory, or tactile. When it's tactile, they're usually describing it as like a itching sensation or a crawling type sensation in their skin. Visual is usually going to be like lines on the walls, or maybe sometimes they'll say, oh, I thought I saw someone there and they weren't, and it was kind of a dark shape. I haven't actually seen a lot of auditory hallucinations, but it can happen. Mostly when people have described them to me, it's been hearing voices of people talking about them outside the room, that kind of stuff. It's important to differentiate these from DTs. So alcoholic hallucinosis is very different from DTs in that the person has these hallucinations, but they're otherwise they're otherwise not delirious. So they usually know kind of where they are, kind of what's going on. They might have some mild confusion, but with DTs, it's a global clouding of their sensorium. So they're very confused and they're very disoriented. With hallucinosis, they should either be somewhat oriented or fairly easy to redirect back to orientation. And usually you can sort of convince them that their hallucination is not real and they can still reason it out a little bit. Or shortly after they notice the hallucination, they realize themselves, oh, that wasn't real. The other thing that is a big difference between the two is that with hallucinosis, while they might have a little bit of fast heart rate, a little bit of blood hypertension because of their underlying withdrawal, it's not severe. So they don't have that significant adrenergic activity otherwise. And then DTs, however, they might have the autonomic hyperactivity, or they will have autonomic hyperactivity where they're quite unwell. So as far as severe withdrawal, this is where we're talking about seizures and DTs. Seizures can happen about usually 10% of the time is kind of the number. These are generalized tonic-clonic. They can present early, as I mentioned, sometimes that's the first presentation. DTs is about 3 to 5% of the time. We're getting better at managing withdrawal, so I think it's closer to the 3% these days. Excuse me, but it's really characterized by severe confusion. They're globally confused. They're disoriented. They will often have some hallucinations as well. It's accompanied by other signs of withdrawal that can be quite significant. Usually you're going to be seeing withdrawal progressing, not responding to benzos until they reach a point where they're totally confused. And they really do need to have the autonomic hyperactivity. So the tachycardia, hypertension, and this is often the reason for complications. So often when people will have DTs, the reason they have to go to ICU is because the medications we have on the ward to manage them are not strong enough at this point. They need like propofol and that kind of stuff. And B, they might go with complications such as AFib or strokes or sometimes a heart attack and sometimes flash pulmonary edema. So it can be quite fatal if it's untreated for sure, or if it's not recognized early enough. The other thing to note is DTs can be really hard to differentiate from benzotoxicity. So if they've actually had too much benzos from the CWA protocol or from the withdrawal management, then they will also become delirious. And usually that happens to line up around the day 2 to 3 mark. So we start wondering, oh, could this be DTs? The rule of thumb that I tend to use is for benzotoxicity, usually a more hypoactive delirium. And with DTs, it's usually more hyperactive delirium. The other thing is that with benzos, they shouldn't have a lot of other observable objective withdrawal symptoms. So their tremors should be relatively treated. They shouldn't be sweaty. They shouldn't have significant autonomic hyperactivity because those aspects are treated with the benzos. They should mostly just be delirious. Whereas with DTs, it's all of the above that we've already talked about. So the other aspect is that when you're assessing someone for alcohol withdrawal, it's important to take a full substance use history. Sometimes it can be helpful to get a urine drug test just to corroborate that. The reason is that if they're also withdrawing from especially opioids or benzos, then it might cloud the picture or worsen the overall withdrawal picture. And then, of course, if they're used to seeing benzos, then they actually might be a little bit too tolerant to the treatment we're giving for alcohol withdrawal. So then they would need higher doses. And then stimulant withdrawal can actually mask some of the alcohol withdrawal pictures, especially within the first 24 hours, because the stimulant crash is where people are just totally somnolent. And so that might actually be masking some of the underlying adrenergic activity of alcohol withdrawal. So this is a study done in 2018 looking at different clinical symptoms that might be able to predict severe alcohol withdrawal. So I looked at 14 different studies. It's trying to find any one particular symptom that might be a good predictor. And the answer was that there was no single symptom that was a really perfect or great predictor of severe alcohol withdrawal. However, what they did find is that there's this constellation of symptoms and historical facts from the patient history that is quite good at predicting alcohol withdrawal. And that's where the PAUSE score comes from. For those of you who have seen this before, this will be review, but for some of you, it might be new information. It's a really good tool. We'll talk about more specifically what it is in a second. But basically we use the PAUSE score to try to predict how severe withdrawal might be, so that in part so we can help decide if someone can go for outpatient versus inpatient withdrawal. So PAUSE score of 4 is found to have a predictive value of 93%, and PAUSE score of 3 or fewer is negative predictive value of 99. So it's quite good. As far as what it is, it's a 10-item scale, combines the history the patient can give you with your clinical exam. It's administered by you, it's not administered by the patient. And we'll go through actually what the questions are in a second. It's the most helpful screening tool that we have for predicting severity of withdrawal. It shouldn't be used as the sole determining factor for whether someone can be inpatient versus outpatient, but it's extremely helpful. I'm realizing you might not be able to see. The top question isn't all that important. It's just, have you consumed alcohol in the last 30 days? So the first 2 questions there are really just to find out if the person is actually eligible to even have a PAUSE score done on them. And then the 10 questions and 10 points are below here. So some of these questions are focused around figuring out how severe someone's withdrawal has been in the past. So there's the seizures, the DTs. Part of the questions there are trying to figure out how severe their underlying alcohol use might be. So have you ever gone through the treatment in the past? Blackouts can be a factor, mostly because that determines amount of drinking. So if they're drinking enough to be blacking out, and they're doing that especially on a regular basis, then that's much more likely to be severe in withdrawal. And then there's a couple of questions there just trying to suss out other substances, because that obviously can affect as we talked about, their alcohol withdrawal. Most of the time, basically always, if someone is using other substances, especially heavily, then they really should be managed as an inpatient if possible. And then the last 2 questions is, what is their blood alcohol level? We don't always have this luxury. So an alternative is, have you consumed alcohol in the last 24 hours? And then, is there any evidence of increased autonomic activity, heart rate, blood pressure, et cetera? A couple of notes about the seizure and DT history. These can be really challenging because patients often don't really know, or sometimes patients are terrible historians. So for DTs, I usually ask people, and if they've been in the hospital, did they ever have to go to the ICU for their withdrawal? Most of the time, if someone has had true DTs, then they may not be able to tell you, oh, it was definitely DTs, but they can at least describe an event to you of being in withdrawal, going to the ICU, was there for a few days, that kind of thing, where it seems clear. And hopefully you'll be able to access those medical records, because it's usually fairly well documented. That said, of course, if they're from a different health authority or somewhere like that, you might be out of luck. As far as seizures goes, patients often mistake tremors for seizures. So if someone tells you, oh, I've definitely had alcohol withdrawal seizures, it's really important to ask a few more questions to find out how accurate that is. So I usually ask people to describe the event for me. Loss of consciousness would be a seizure, versus if they remember the whole event, then it's likely tremors. If it was witnessed, then they were probably told that they were seizing. So, I mean, when I ask people to describe the event for me, if they tell me, oh, I was in such bad withdrawal, I was shaking, I could barely stand up, I could barely walk across the room, but they could walk across the room, or they were conscious the whole time, that's not a seizure. Versus, if they're able to describe something where they had stopped drinking and they had all these symptoms, and then next thing you know, they woke up on the floor, I would usually count that in my history taking as having had a seizure. So if a person's PAUSE score is less than or equal to 3, they could be an outpatient management candidate. This is important for avoiding unnecessary admissions. So it's a way to decrease healthcare costs associated with withdrawal management and overall with alcohol use disorder. Obviously, it's cost effective for that reason. And for patients' purposes, it's less disruptive to their lives. It is important, if you're going to consider outpatient management, that this person is reliable for follow-up. Ideally, daily check-ins could be by phone or with visits. If you can't do daily check-ins, at least every couple of days would be really important, at least for the first few days. For that reason, it can be helpful to start on a Monday or Tuesday so you can follow them throughout the week. It has to be a person who's going to be reliable to take their medications that you might prescribe. And it's also important to have someone, if possible, who has a reliable companion who can stay with them or check on them regularly, especially at odd hours of the day, to help make sure that they're okay. And if we're going to go down this outpatient management route and they have someone who can be involved, then if possible, I usually try to involve that person in the discussion so I can give them a little bit of training of what sort of things to look out for. As far as outpatient treatment goes, we really should be using a non-benzodiazepine approach. And the reason for this is for someone whose PAS score is less than 3 and you think they might be appropriate for outpatient withdrawal, they should be having a mild enough withdrawal that they don't need benzos. So the medications that we use would be carbamazepine, gabapentin, and or clonidine. I've done gabapentin a few times and actually had some pretty decent success. I've only done carbamazepine once with a person, but a lot of the people, to be fair, that I'm seeing, they're above a PAS of 4, so they're not really outpatient candidates. But either way, we're not going to go through all the dosing protocols for these, but in the alcohol use disorder guidelines on the BCCSU website, it does lay out specific prescribing, how to prescribe these medications and doses per day, etc. So it's really nicely laid out and easy to refer to. Outpatient benzos are discouraged. The main reason, well, the main few reasons is because there's a significant risk of relapse to alcohol. Of course, combining benzos with alcohol has significant overdose risk. And then if they're driving, there's risks for that kind of stuff. There are a few cases where I might do a benzo withdrawal. These situations are usually more if I'm working on the consult service and I get a call from a clinician on like Saturna Island or somewhere that doesn't have really healthcare, and the patient is totally unwilling to go into the hospital, and they're unlikely. I don't think they're likely to progress to the point of DTs, for example, but maybe they've had a seizure risk 5 years ago. In a case like that, and they're reliable to follow up and they have someone to help with them and they don't have other reasons to be admitted, a case could be made for potentially doing benzos. If I do that, then I would usually suggest keeping it a very short course of benzos. You might consider daily dispense depending on the person. And I usually do like 40 or 50 milligrams day 1, 30 or 40 day 2, and then kind of so on from there. So really trying to make sure I'm not just giving them a free for all of benzos to try to withdraw. If a person's PAS score is greater than or equal to 4, they most likely require inpatient management using benzodiazepines to help prevent seizure and DT risk. Benzos have a really high efficacy rate for preventing complications from alcohol withdrawal. There's been many, many reviews done on them. Some of you may be seeing that phenobarbital is starting to come back in style, but for the most part, benzos are really still the standard of care. Most of you have probably seen CWAS before or even done CWAS. This is a 10-item scale looking at the severity of alcohol withdrawal. It's symptom triggered. And the reason that we like using symptom triggered is because A, it's been shown to be effective for preventing significant withdrawal, but B, it's also been shown to be effective to avoid dosing benzos when they're not needed. And that helps reduce people's length of stay, which is overall better for them. CWA is not without its faults, and we'll talk a bit more about that in the next slide, but it really shouldn't be used when a person is unable to communicate because it requires questions and answering from the patient and accurate answering. So different situations, language barriers, cognitive impairment, those kinds of things might be reasons that a CWA is not going to capture an accurate picture. I also find sometimes there's very confounding factors with a CWA. And so someone might be admitted, for example, with pancreatitis. Now they have significant nausea, vomiting, for example. That's going to confound the CWA. And so I guess the caveat there is I would just say if you're assessing someone and their CWA score is fairly high, it's really important to see what they're scoring for and what else might be explaining those symptoms in order to understand how much of this might be alcohol withdrawal, how much of this might be a different reason that they're in hospital. Another thing to think about with CWA, if the person has a known tremor, alcohol masks these essential tremors. And so now we've removed alcohol, that's going to bring out more of a tremor. An essential tremor is not the same as an alcohol withdrawal tremor, but it can be really, really hard to tell those things apart. So it's going to make their tremor look worse than it actually is from a withdrawal perspective. So a trick for that is you could potentially have them stick their tongue out, and you can actually look for fasciculations on the tongue. And if they do have fasciculations, then that is alcohol-related tremors. I was just going to point out that sometimes when we can't use CWAS for the reasons that we've talked about here, some people, usually under the care of addiction medicine specialty, you can start using or looking at doing more objective objective alcohol withdrawal scales. I've done this lots of times with patients in the hospital when these sorts of factors that we've talked about are present. There was actually a study done, it was a case study, I think it was by one of the BCCSU fellows in 2017, where they had a Polish speaking man who had fallen and hit his head. So he had a mild head trauma and he really couldn't speak English and not very well. And he was being assessed for alcohol withdrawal. And they were able to use translation services at times, but that wasn't always available, especially into the night. And so they were having a hard time assessing his withdrawal, and he was getting more benzos than needed. It was hard to tell. So they switched to an objective score, and the score picked out just observable signs that the nurses could just look at the patient, check their vitals, and then fill out the score. And so they looked at heart rate, blood pressure, visible sweating, visible tremor, and agitation. And created a scoring system for that, and then gave benzos depending on what score they had. And it went really well. I've actually used that exact score multiple times, and it goes really well. But like I said, it's likely something that would be done under the care of an addiction medicine specialist, but you can always call the 24/7 line that's available in BC or the RACE line to get some tips around that. Just if you're in a situation where you think CWA is maybe not appropriate and they're getting too much benzos, might be a reasonable option. So all patients who complete withdrawal need to be connected with continuing relapse prevention. And now we'll talk about what that is. Before we move on, does anyone have any burning questions about withdrawal management that we can go over?
Feel free to just unmute yourself if anybody has a question.
Okay. I'm going to assume it's because I'm either talking way too fast and you can't tell what I'm saying, or it's going really well. All right, so when we're treating people for alcohol use disorder, we're overall trying to accomplish a harm reduction and decreasing harm or consequences to their overall health. And we can do this, sometimes we can do this by an abstinence approach. That might work really well for some people, but for some people, it's going to be more of a harm reduction approach. So that's decreasing drinking days, decreasing the number of drinks they have on heavy drinking days, and decreasing the overall number of drinks in a week. And these are the parameters that most studies are looking at when they're assessing pharmacotherapies. It's really important to develop goals with your patient that make sense for your specific patient so that your overall treatment plan is individualized to them and their context. And with this approach, we're going to be able to help restore their day-to-day functioning. So as far as achieving these goals, I think a lot of it comes down to the spirit of the interview and the spirit of the approach that you bring to the practice. It's really important to talk with your patients about the hope that there is for alcohol use disorder. A lot of patients with any substance use disorder, but a lot of people drinking heavy amounts of alcohol, if they've been doing it for most of their life, they're likely feeling very hopeless about it. Hopelessness and guilt and shame is a really, really difficult part of addiction and a difficult part of the mental health and behavioral side of addiction. And so bringing empathy, bringing hope to the conversations that you have with your patients can be really life-changing for them. It can be helpful for some patients to explain how alcohol has affected their brain, why things are happening, and explain how the treatments work to help change that, in thinking both about withdrawal management, but also in thinking about changing the way that the reward cycle in their brain is being fired so that we can move away from cravings and move into better trigger management. So all patients with alcohol use disorder should be offered pharmacotherapies, psychosocial treatments, and then different recovery supports, which we'll talk about in a minute. The recovery supports available are likely going to be somewhat geographical. So different places have different access, but there's a few that are more province-wide, and we'll talk a bit about that. And one thing I often tell my patients, a lot of people will need to try recovery multiple different times. Most people don't get it the first time they try it. And as much, maybe that will be a lack of hopelessness for some patients, but I think it's helpful to just encourage them that wherever they're at, we're making changes. And even if they end up having a relapse, it's always worth trying again. On average, most people who are trying to quit using substances have to try at least 7 different times before they actually have an approach that sticks. So I also use this to encourage patients that maybe whatever they worked or whatever they tried 10 years ago and hated, they're in a different place now. They're a different person now. Maybe that approach might actually work now if talking about counseling or those kinds of options. Okay, pharmacotherapies for treating alcohol use disorder. Everyone with moderate to severe use disorders should be offered pharmacotherapy. There's a little bit less evidence in treating mild use disorder. However, if cravings are a big part of their picture, then that would be a especially important time to be offering it. I offer everyone, whether they have mild, moderate, or severe. Can definitely lead to improved outcomes, preventing return to drinking, reducing the number of drinking days and number of drinks in a drinking day, like we talked about in the slide as far as targets goes. But pharmacotherapies are very much underutilized. So less than 10% of patients with alcohol use disorder are offered pharmacotherapy. These are the medications that we typically use. There are third and fourth line medications. We're not going to talk about them tonight. We're mostly going to focus on these ones. So we've got acamprosate and naltrexone. Disulfiram is an approved treatment, but it's not recommended. This one was shown to cause too many significant adverse events to justify prescribing it. That said, for some people, it does work really well. That's more for people who have been on it for maybe 20 years and totally stable. I might continue prescribing it in those cases, but it's quite rare that I've prescribed that one just because the adverse events are so high, and it is pretty significant health risk for some people if they ended up drinking while taking it. The off-label medications that are second line that we'll talk about are topiramate and gabapentin. So for the first line options, this is that 2014 meta-analysis that I showed you at the very beginning. It looked at the 122 RCTs. Found that acamprosate and naltrexone were both associated with significant reduction in return to drinking. And then it did compare or look at RCTs comparing them to each other as well, found that there was no significant difference between the two as far as the outcomes of reduced drinking, reduced number of drinks, etc. Several other reviews have been done, and in general, they found that naltrexone seems to be more effective in reducing heavy drinking. Acamprosate seems to be more for the context of supporting abstinence. However, both can be helpful for both. So that's not totally clear cut, but if you have to choose, then that would be the two different contexts of reduced drinking. I'd say reduced drinking or abstinence, and then just abstinence. And of note, both of them have a number needed to treat of 12, which is really impressive. As you can see here, these were just some NNTs pulled for other common interventions that were taught to prescribe people. And our numbers are very good for treating alcohol use disorder. So that's part of the hope side of things. We can offer hope to our patients because there's good evidence behind these treatments. Bit more specifics about naltrexone. It is a mu opioid antagonist, so it blocks the mu opioid receptor. The mu opioid receptor is heavily involved in the reward pathway of the brain, which is both firing when the patient is consuming alcohol, but it's also firing when they start having triggers and cravings for alcohol. So that's what cravings really are. For example, someone, maybe they always drink at 5 o'clock when they get home from work. So they get home from work and that reward cycle is already starting to fire for them and creating that craving, which then becomes more and more difficult for them to overcome. So naltrexone, it helps to block that. It doesn't totally, well, for some people, it takes away the cravings completely. For most people, I tell them that it's unlikely to completely remove the craving, but it will help reduce the intensity of the craving so that all the other work that they're doing and their own willpower and their own support networks will help with the rest of it. The recommendation is to start at either 12.5 or you can start at 25 milligrams. And I usually increase that. You can go 12.5 to 25 and then up to 50. I give them about 3 or 4 days at each dose before increasing them. The max is technically 50 milligrams, although there are cases where someone might be at 50 and they're getting partial benefit, but not full benefit. For those people, as long as their liver is fine, you can justify increasing to 75 or even 100 milligrams. From a safety perspective, it would be ideal to get their liver function testing at baseline and then recheck it at 1, 3, and 6 months. Naltrexone does have a risk of hepatic injury associated with it, so it's important to talk to your patients about stopping it if they have symptoms of acute hepatitis. I've seen hepatic injury from naltrexone. I can count it on one hand as far as I prescribe it a lot. But overall, you're unlikely to cause liver injury, but it's something that I think is important to talk about because for some patients that would deter them from wanting to take the medication. If someone has had liver enzymes that were, if I'm seeing them in an outpatient setting, they've had liver enzymes, say 8 months ago, and they were normal, they haven't had changes to their health since then, and I have no reason to think that they have any sort of like acute liver injury, then I don't necessarily repeat the liver enzymes before prescribing it, but I would check them a month later and make sure that everything looks okay. From a side effect profile, most commonly we see nausea, headache, and dizziness. Usually the symptoms are pretty mild. And the nice thing is they're usually self-limited, so they go away about 1 to 2 weeks after taking it. So if the patient can tolerate, I always encourage them to try to power through, and eventually they'll go away. They usually do. For some people, they don't, in which case you might reduce the dose or actually stop it and try something else. There are really only 2 contraindications for naltrexone. One is current opioid use because of the receptor antagonism. So for people who are either in acute pain or you anticipate they're going to need opioids for pain control in the immediate future, so pre-op or something like that, then you can't prescribe it. Or people who have acute hepatitis or liver failure. This is an important one to think about. There's technically no ceiling or max liver enzyme number after which you can't prescribe naltrexone. It's all context dependent. And that's this point here. So naltrexone is better for the liver, most likely better for the liver than ongoing drinking. And so when you're trying to figure out the risk benefit for starting someone on naltrexone, if they do have some amount of liver injury, it is likely safe and can be prescribed in people who have compensated cirrhosis. It's definitely not recommended in acute liver failure. That said, if I have someone who's admitted to hospital, I see them early in their admission for their AUD, they have acute hepatitis. As long as the liver enzymes are trending down during that admission, then I'm happy to start them on naltrexone before they're discharged. I see a question there, I think. What do you do when there's end-stage liver disease with LFTs that might not be mounting due to burnout liver? How do you determine this accurately with LFTs that might not be mounting? Oh, I don't think I've really encountered that all that much. I think that it's still at that point in time, it's unlikely to be causing significant liver injury. It would still, if they have end-stage liver disease and it's really that severe and they have other signs, especially of decompensated liver disease, then I wouldn't be prescribing it. But if they have end-stage liver disease and it's compensated and they don't have other symptoms that are suggestive of decompensation, then it could be a reasonable option to still prescribe naltrexone and follow them closely clinically. In patients like this, I would recommend acamprosate over naltrexone. That said, if it's someone who has either failed acamprosate or don't tolerate it, or maybe they have renal failure or any of those other reasons to maybe try naltrexone, I think you could still justify prescribing naltrexone as long as clinically it doesn't look like they're decompensated. I would never prescribe it for someone who's decompensated. A patient where IM has suspected this. What did IM say, or were they in hospital? Was it an outpatient? What was the context there? If in hospital, yeah, LFTs are not high. And so internal medicine said that they just weren't able to mount the response. And yeah. And clinically, were they decompensated? They suspected that. Yeah. So if they're decompensated, then I wouldn't prescribe it. If you see someone in an outpatient who likely liver transplant was recommended. Yeah. So if someone's at the point where they likely need a liver transplant, I'm unlikely to prescribe naltrexone. Yeah, it's a little bit too high risk. Yeah, good question though. Okay. Oh. Any other questions about that? I know that's a question I get calls a lot about as far as when to or not prescribe naltrexone. Okay, sounds good. We can always come back to that if needed at the end. So we'll move on to acamprosate. the mechanism of action is really not all that well understood. It's thought to restore the imbalance between the GABA and glutamate, but we don't totally know. The dosing, the max dose is 666. Well, the recommended dose is 666 3 times a day. We usually start at 333 3 times a day for about 3 or 4 days, and then increase it up to 666. Safety considerations have to be taken into account if a person has a decreased kidney function. So if their clearance is less than 50 but greater than 30, then you can still prescribe. It just needs to be at the half dose. The contraindication for a kidney function perspective is a creatinine clearance less than 30. From a side effect perspective, most commonly loose stool, vomiting, abdominal pain. Again, like naltrexone, it's usually self-limited, although I've had patients who have had loose stools ongoing, just not severe enough to stop taking the medication. Most of the time it will go away within the first couple of weeks. Again, if it's not going away and they're at the max dose, you could always decrease the dose and see if it becomes tolerable, but still effective. And then if still not, then you might try something else. The other contraindication is breastfeeding, and I was trying to find why this is. I couldn't find any studies that said any documented harms. So I believe the reason is that some animal studies were done and found that acamprosate was secreted in breast milk. And I mean, we have no idea what the effects, because it hasn't been studied, and what the effects might be for a young child. So I couldn't find anything else. If anyone else actually knows exactly the answer to that question or has read about it, then I'm all ears. But that's what I could find in my brief literature review about that contraindication. If you haven't heard anything either, then I'll move on. I don't have a lot of pregnant and breastfeeding patients, so it's not always I often defer to my perinatal colleagues on these things. First line treatments, how do you choose between them? We've talked a little bit about that. Overall, naltrexone, if the person says, well, I only want to reduce, I don't want to quit, then definitely I'm going to go the naltrexone route. If they say, I definitely want abstinence, I would choose either one. It usually comes down to contraindications and then dosing schedule. So if there's no contraindications and say the person wants abstinence, then I would say it comes down to dosing schedule. If the person is at all ambivalent and I'm mostly trying to drag them along and convince them to take a pharmacotherapy, then I'll go the naltrexone route if there's no reason not to prescribe it, just because once a day is so much easier and so much less intrusive compared to 3 times a day. That said, if a person is already on other medications multiple times a day, then perhaps acamprosate 3 times a day doesn't make a big difference to them. So I think it's important to understand from your patients how they generally feel about taking pills, because it's only going to work if they actually take it. So from a pragmatic perspective, you might as well prescribe something that they're actually going to take. Response to these medications seems to be improved when you start it 3 to 7 days after achieving abstinence. So in their subacute withdrawal period, so after they've gone through the initial worst symptoms of things. But it's safe to take while drinking. And so if someone comes to you to see you in the office and they don't necessarily want to go through the withdrawal period or whatever, and maybe they just want to reduce drinking, especially for naltrexone, then you can start prescribing it while they're actively drinking. And on that note, if they stopped drinking and then they have a relapse, it's actually really important to instruct them to continue to take the medications, because especially naltrexone, but both of them, I've had patients tell me that it's helped them actually reduce the number of drinks that they might have if they relapse, or it might reduce the intensity of the relapse and help them get back on track faster. So always tell them that if they did have a drink, it's safe, just continue taking the meds. So second line options, if there's no benefit in the first line options or there's contraindications to both, then this is where we're going down these routes. The options that we have are topiramate and gabapentin. They haven't been compared to each other in clinical trials, but both have been found to be effective in their own individual trials. So topiramate is an old anticonvulsant. This was a meta-analysis done looking at 7 different RCTs, reported small to moderate effect in abstinence and decreasing heavy drinking compared to placebo. And interestingly, the number of patients that received a benefit was similar to acamprosate and naltrexone. It's just that the degree of the benefit was a bit less. So you start at 50 milligrams a day, can increase it by 25 milligrams weekly, up to a max of 100 twice a day. And for patients who are having side effects, there's some studies that show that a dose of even just 75 milligrams per day can be helpful. So some people might get benefit even at a low dose. It's kind of nice to have that large dose range for people. Just gives lots of opportunity for titrating it depending on effect. The big limitation for topiramate is the side effects. Most people seem to get some side effects on topiramate, so it depends on whether they're tolerable or not. And topiramate is contraindicated in pregnancy, or so if people are planning to become pregnant, it should not be prescribed. Gabapentin has been found to reduce cravings and decrease rates of relapse and increase number of days to relapse. So increasing number of sober days before a relapse happens. The dose is, you start at 300 milligrams total in the day. So I usually start them on the TID dosing schedule. So doing like 100 3 times a day. And then you can increase by 300 milligrams per day. I usually give them a couple of days to adjust up to a max of 600 TID. So the studies looking at gabapentin found that a total daily dose of 900 up to 1800 was effective, but it was most effective when it was 1200 to 1800. So 400 TID up to 600 TID. So if you can, I try to encourage, as long as they can tolerate the medication, I encourage patients to get up to those doses, just to know that we're at least trying to maximize a therapeutic benefit. Side effects, as most of you will know, can be a big one for gabapentin. So the dizziness, the somnolence, also edema can be a big factor with gabapentin. So going to be a little bit more cautious depending on the patient context of when you might prescribe it. So if they're on other sedating medications, it could be a reason not to, or a reason to stay at the lower doses. Pregnant or breastfeeding, people over the age of 65 because of the potential cognitive effect and the falls. And then gabapentin does have some risk of diversion. It seems to me somewhat geographical. We don't have this as a big issue in Victoria, at least not that myself or my colleagues have seen, but I've had colleagues in Vancouver tell me that it's more of an issue there. So it sort of depends on the local flavor of substances that's going on in your area. Medication coverage, always an important one. Naltrexone and acamprosate are both covered by Pharmacare, but the prescriber must have signed the collaborative prescribers agreement, which is through Pharmacare. It's just once in your whole career, so I definitely recommend that everyone does that after this talk if you haven't already. The other thing to note is that both naltrexone and acamprosate are covered by Plan G. So if someone has Plan G, but their prescriber has not signed the the collaborative prescribers agreement, it won't be covered. And vice versa. If you've signed it, but there's no Plan G in place, they might still have to pay for it. So it's important to have both. And most extended health benefits will also cover naltrexone, acamprosate. First Nations Health Authority does also cover them. And as far as these other options, topiramate, gabapentin, the baclofin's included here. We haven't talked about it. It's a third line, I believe. Either way, these ones are covered by Pharmacare, but only after the deductible is reached. And I don't believe any of them are covered by Plan G. I know gabapentin's not.
Kelsey, there's another quick question in the chat there.
Sure.
And I was just going to say too, maybe you could read it out if you don't mind, just so that because it's recorded, nobody will see the chat. And so if you read it out, then they'll know what you're answering about.
This first one is any safety consideration for, hang on. This first one was actually this one. Another question, naltrexone. Can you comment on a dose greater than 50? I saw one patient on 100. Yeah, so it's a good question. It's case by case. It's kind of like SSRIs where you start lowest effective dose, and if they're getting a partial effect, then you can potentially increase further to the max. I know the max from the monograph is 50, but I've had people on 100 who have reported significant benefit from that. So the patients that I think you would consider doing that is where they've been on 50, they say definitely helping with the cravings. There's a noticeable difference. They're not having intolerable side effects. Their liver is tolerating it just fine. Then you might try an increase of 25 up to 75 per day. And if they continue to get improved benefit on that dose increase and maybe not full benefit, then you might try 100 milligram dose. And again, if you're putting them at those, then you again want to recheck liver enzymes a month later to see what's going on. Did that answer your question, Danielle? Okay. And then safety consideration for concurrent use of naltrexone and acamprosate with antipsychotics. Not that I'm aware of. There was a psychiatrist I worked with at Vic General that had some concern about starting acamprosate with one of the antipsychotics, I believe, because she thought it might have a serotonergic effect. But I have not found that in the literature as far as contraindications go. So I would prescribe them both. And certainly compared to drinking on an antipsychotic, it's definitely favorable to be taking the medications. So not that I'm aware of. I've looked into this a little bit and was not able to find any significant interactions. Okay, we'll move on now away from pharmacotherapy. Happy to go back to that and answer other questions towards the end though, if we need. Psychosocial treatments, motivational interviewing. I'm super biased about this because I think it's a really important intervention for all clinicians to have some comfort level with, not just for substance use disorders, but really all patients with alcohol or any substance use disorder should be receiving some motivational interviewing from their clinicians. It's an interviewing technique. So we talked about before, it's patient oriented, it's often a harm reduction lens, it's goal focused, in basically using a technique of reflective listening to try to evoke from patients what their concerns about their health might be, what their goals are, where they want to get to, and then helping them identify how they're going to get there. And so I usually find with patients, I'll tell them, I have all the ideas in the world of how we might achieve their goals of abstinence, but it doesn't matter what I tell them if they're not going to do it. And so I usually try and get my patients to come up with their own plans about how they're going to achieve whatever their goals might be. It does not require specialization. There are lots of courses for it, but you don't have to have a course to be able to do it. It really just takes practice. It's nice to do a little bit of reading around it. There's all kinds of books out there. I can talk a bit more about that at the end if you want to, but it's definitely a good skill to have. And it's been studied. It has shown small but significant improvements in outcomes. In particular, I think motivational interviewing can be helpful for creating that safe and hopeful and empathetic space where patients are going to come back to you for support in their addictions. Specialist-led interventions, we're talking about CBT, family-based therapies. Usually these are going to require referrals to people who have certification in these particular areas. CBT in particular has been studied and again has found small but significant treatment effect on duration of abstinence and relapse prevention. And there are lots of online resources for CBT too, but I think for it to be done really, really well, it's helpful to have it done by like a counselor, for example. And then there's peer support groups. So this is AA, Smart Recovery, Life Ring. AA is and NA are the 12-step approach. Smart Recovery and Life Ring are a non-12-step approach. So for those patients who come to you and say that they hate religion or spirituality or whatever and have no interest in trying the more AA spiritual type approach, then you can still offer things like Smart Recovery and Life Ring. The really nice thing about these, of course, is that they're no cost, they're low barrier, they're everywhere. So it's, they're in pretty much every town and every location. Smart Recovery actually has an online resource, which I direct people to quite often, especially if they claim to be kind of lone wolves and not wanting to do group stuff, then I'll direct them to the online resources. There is a lack of evidence saying that peer support groups are all that effective in preventing relapse. However, patients who attend these groups, it's obviously self-selected, but people who attend these groups report benefit from the community atmosphere, the feeling of acceptance, sometimes getting in touch with their spirituality or just sort of self-identifying their own sort of patterns and such. So yeah, I mean, there isn't a lot of literature to necessarily, there's some literature to support them, but as far as from RCT level, it's also really hard to study out that type of level of evidence. So that's part of the reason for the lack of it. Either way, though, some patients are going to benefit. And as I mentioned before, I usually try and provide a menu of options and help my patients to navigate and try a few different things. Okay. So quick summary, and then we'll open up for questions. So universal screening is extremely important. Everyone that you have in your practice, you should be asking about alcohol use. You don't have to have red flags or signs showing up in their emerge encounters or their lab work that suggests they have it. It just should be asked about if you can remember. And helpful ways to remember is developing familiarity with some of the screening tools or just getting used to asking those one-off questions. The pause score, this is a really important triage tool for understanding low versus high, or sorry, predicting low versus high risk of withdrawal. And in that vein of thought, whether they might be an outpatient or an inpatient withdrawal. So patients with alcohol use disorder, moderate to severe in particular, need to be offered the first line options. Naltrexone, acamprosate, we talked about those. We can go over that again if anyone wants a bit more info. Patients who don't benefit from those or have contraindications can still be offered the second line options to pyramid or gabapentin. And then the BCCSU guideline has the third and fourth line options also laid out. We don't have time to talk about all that stuff. And I haven't really prescribed them very often because I haven't found them to be as effective as I'd like. There's also enough options within naltrexone, acamprosate to pyramid gabapentin that you're likely going to find something that will work for your patient there. Primary care clinicians should be providing, well, not just primary care, everyone should be using kind of motivational interviewing based approaches to help people identify their goals and get towards their treatment goals. And then referrals may be appropriate, including information about peer support groups and treatment referrals, that kind of thing. Okay, I think that's everything. Thanks for sticking with me. Does anyone have questions? I'd love to chat about cases or anything else.
I see one new question that's just popped up in the chat, Kelsey. Okay. Can you use naltrexone on a PRN basis, i.e. if someone is going to a party to help with drinking reduction?
Absolutely. This is referred to as the Sinclair method. So it's the as needed method of naltrexone. There is some evidence that it works. It doesn't seem to work as well as taking it every single day as far as specifically management of their cravings. And maintaining abstinence. But usually what I tell people when I start them on these medications, I recommend that they start them for and plan to be on it every single day for a full 3 months and then reassess. And then I find for most people, especially if the idea of being on medications is it's a really unfavorable one, then it makes it a little bit more bite-sized so they don't feel like they're signing their life away to taking medication every day. So I usually recommend that they try for the first 3 months. That's the most vulnerable period as far as relapse to substance use goes. And so it gives them an opportunity to really establish their support system, maybe get in touch with counseling or other things that are going to work for them that are the non-medication side of things, and get some of those recovery tools in place. And then they can think about maybe going off the medication if it's naltrexone, then using it as needed basis. If they're doing that, then it's safe to, because they've already been presumably on the 50 milligrams, then it's safe to just take a 50 milligram, before their social gathering. If they're going to do that, I usually suggest that they take it the day of, but not like an hour before. So take it sort of in the morning and then they go to their gathering in the evening. Good question.
There's another question. Could you comment on common drug interactions with the AUD medications?
Did you have some medications involved? I can't say would be referred over naltrexone. Because apart from the opioids, there aren't interactions that I am usually particularly concerned about.
Okay. Another question that just came in. Is there a time that acamprosate would be preferred over naltrexone? Is it just the 3 days just versus once a day?
Yeah, so I mean, it comes down to what if they have liver failure versus renal failure. So acamprosate is contraindicated if they have significant kidney disease or kidney failure, whereas naltrexone is contraindicated if they have liver failure. And then acamprosate in the studies has been shown more effective if it's an abstinence-based approach, whereas naltrexone might be effective if the goal is either abstinence or reduction. And then acamprosate, I find it often comes down to the 3 times a day, or go for acamprosate if on opioids. I find acamprosate versus naltrexone often ends up coming down to the dosing schedule.
Dr. Chapman did just add a little bit to say that she was looking specifically at whether there are any interactions with antidepressants or PPIs.
Yeah, not that I'm aware of specifically. I do know that naltrexone, it wasn't statistically significant findings around actually causing low mood, but there was some observable effects in follow-up studies for patients who were on naltrexone who sort of developed a worsened mood. And then when they were off naltrexone, they actually did better. So presumably for some people, they might be more sensitive to that opioid blocking effect as far as dampening the reward pathway in the brain and worsening mood. I had one patient where that was definitely an observable effect. But it's pretty uncommon. As far as interactions specifically with antidepressants, I can't think of an antidepressant that I would not prescribe in context of these medications. So if you have one, I'd love to hear about it, and I can do a little bit more of a deep dive around it, but I don't have any that I wouldn't prescribe. I would say that there's a little bit of evidence in treating mood disorders using sertraline for alcohol use disorder, but I haven't read enough of those papers to be able to speak more statistics around that one. So it depends on the patient. So I usually, as far as the medications goes, Geraldine, the prescription. Yeah. It depends on the patient. As long as I have their attention and can convince them to take a medication, I will prescribe it. And I usually, so minimum 3 months. I tell people minimum 3 months, better outcomes if they can stay on it for closer to a year. But it's going to depend again on the patient. For some people, if they hate taking a medication, then they're not going to take it anyway. It doesn't matter if you recommend them to be on it for a whole year. For some people, they really dive deep into their overall recovery planning and they're doing really well. They're super engaged in non-pharmacological interventions, maybe getting back to work, all these kinds of other protective factors. Those people might actually do really well with actually backing off the medication early on because they have so many other supports in place. So I usually tell people if they can tolerate the medication and it's not a significant distressing factor for them to be taking a pill at all, then why not stay on it for longer? Because it might be helping. And if the risk is potentially relapse to alcohol, then it's worth staying on it. I think, yeah, I would say most people will probably stop within about a year if they're abstinent in that time, but I say minimum 3 months. Welcome. Any other questions?
I'm going to jump in if there's no questions, Kelsey. I'm also a really big fan of motivational interviewing and just wondered if you have had any kind of great successes with using motivational interviewing, like what kind of questions you pose to get people thinking along that lines of making changes and being open to that.
Yeah, I don't have a script that I follow, but some of the questions that I find really helpful is even just at the beginning of your conversation with them, whether it's about substance use or for diabetes or hypertension or whatever, I'm just trying to identify with them and establish what their priorities are for that issue. So it can be a lot to say, like, what are your health priorities? But if you're talking to someone about their alcohol use, then I usually try and ask them, what is it that you want out of your goals, or what are your goals around alcohol use? And they'll say, I want abstinence. And I say, why? I'll ask them, why do you want abstinence? Why isn't it okay for you to drink anymore? Just so I can really start to understand what's led them to that point and led them to that decision. How is it impacting their life? And once you understand, most people are going to tell you, like, perhaps there was a specific event that happened where they got caught and their relationship is breaking down or whatever. You can start to understand what their specific priorities are for themselves. As far as why they have to stop drinking, what it's impacting. Some people, actually a lot of people will say, or not me, they'll tell me, I realized it started to impact my health, or I saw my friend die of liver failure. I don't want that for myself. So those are the things that you can pull on to help motivate people if they're having a low moment and they're maybe thinking about going back to drinking, or they've already relapsed or whatever. Then those are ways that you can kind of reinforce their goals for themselves. So a lot of motivational interviewing is around identifying what someone's goals are, and then identifying where they're at right now and helping them draw the conclusion that they're not where they want to be, but we can get where they want to be. Other specific questions. I used to have more specific questions when I was kind of first practicing it, but now I can't remember what they all are, and not on the spot. Yeah, but I think it's just important to help them come up with the answers. You're very welcome. Glad to be able to share.
Thank you. Any final questions out there, or any cases that people are struggling with? If not, we can let you go a little bit early tonight. Just give it like 10 more seconds, maybe.
I was thinking the one thing I was going to add around the naltrexone piece and liver failure is just a case that I had that I thought was an interesting fellow who had been admitted to hospital multiple times in decompensated cirrhosis. And I saw him during the time when acamprosate was actually on back order. So we didn't have it as an option anyway. And he'd had some benefit from naltrexone in the past, but it had been discontinued on past admissions because of his liver failure. And when I saw him in follow-up, he was in hospital for quite a long time. And so I saw him in follow-up when he was no longer in liver failure. His numbers were generally improving, but it's more his clinical picture was generally improving. He actually he was quite jaundiced. Like he really kind of looked like a highlighter still. And it was really quite sad. But that was a case where we actually did start naltrexone, and I just had a really honest conversation with him about the risk that it potentially would pose to his liver. In his case, and in cases where someone has an at-risk liver, usually we would do liver enzymes like 2 weeks and then 4 weeks and then and so on like that, just to monitor. And so we made that plan to monitor his liver really closely and clinically monitor him to see if any symptoms are coming up. But yeah, we started naltrexone for him, and at least in the short term, he did pretty well. I didn't have long-term follow-up, but just to give an example of it, it's possible to, in the context, it's possible to prescribe it if someone is motivated to be taking it. They've had benefit in the past, and it's better than alcohol for their liver. So it's worth a shot.
The BC resource site for addiction management you mentioned early in the talk, I'm not sure. I was just typing in at the same time that the phone number for the BCCSU 24/7 helpline. But was there another resource that you mentioned? I know you would put in the one with the drinks, like the drink converter. Maybe that's the one.
Yeah, there was that one. Are you talking to me or?
Well, I am talking to you. Yes.
Sorry. Yeah, there was a UVic standard drink calculator. There's the 24-hour, and then the Raceline usually has an addiction medicine physician on.
The nice thing about the BCCSU helpline is that it's accessible for nurses and other allied health, whereas I think Raceline is still predominantly just for physicians. I could be wrong, they might have changed that now, but just a nice option for clinicians if you're working after hours or on weekends to have a helpline that's available for you there too. Well, thank you, everybody. We're going to let you go, and I thank everybody for coming tonight. Thank you, Kelsey, for a great presentation. If anybody has any questions to follow up, feel free to reach out to me anytime. Yeah, have a good night, everybody. Take care.